All right, looks like we have a full table. Did you see more individuals in the hall by chance? Okay.
Gail's in the restroom. I saw Gail in the restroom.
I don't have to sit together. Unless you
Hi,
want
Roger.
to.
We don't have to hear.
You can sit across and make eye contact. All right, you guys ready to get started? Looks like we have a full house. Morning, Gail. Morning.
Yeah, they said that we couldn't sit next to each other.
We separated you guys.
We have an hour and a half next to each other.
All right, welcome to the first WPCC meeting for 2019. Happy New Year to all of you. I think that will be the last time I say that. Said that 3 times already, so here I am saying it a 3rd time. So, and let's get started. I'm going to do a couple things different today. Normally we just do a simple roll call, but today I'm going to say let's do a roll call and tell me your name, your organization, and tell me one thing you would like to see accomplished this year as it pertains to the WPCC. And that could be within the organization, it could be within the collaborative. Whatever you choose, what do you want to see? What do you look forward to in 2019 that you would like to see accomplished? And so, are you giving me directions over here? Okay.
Oh, Chris, good.
Okay, Chris, go for it.
Thanks, buddy. Chris Development, Catholic Charities. One of the things I'm looking to accomplish this year is real-time data. Really looking at how can we show what productivity is and be able to look at it across the system.
Chris, we'll go with you now.
Oh, Chris Davis, Catholic Charities, and I guess my goal, which is speaking by day, is to get the medical clinic open within Catholic Charities
Next week.
next week.
I think that Mike Lopez, Grand Integrated Services. The one thing that I would like to see, actually, just to continue, is the partnership within the community, and to continue to grow towards the integrated care, whole person care. So, outcomes for people, better healthy lives. So, that's what I got.
Fun.
Charlene Tilley from the North Central ACH. Am I answering the question as well?
Yes.
Sure.
All right.
You're part of this.
I think for 2019, I'm hoping we can get all the process, change plan templates and things behind us, and then really work to support you in implementing the changes you want to do. So,
Wendy Bresney, North Central ACH, and I'm looking forward to collaboration amongst those within the collaborative. It's already starting, and I'm looking forward to more of that because I always enjoy these partnerships and how they form and what each of the organizations get out of it.
So Linda Parlett, Executive Director of the ACH, and I am looking forward to getting data, accurate data, possibly more current data from the state of Washington because we've been asking for it for too long.
Melody White, Family Health Centers. I think probably our biggest struggle is data for making sure that we have a way of incorporating in the quality aspects of the change plan and the kind of proof in the pudding stuff to make sure that what our efforts are worth it, the effort that's going into it. And I guess the most exciting thing is seeing it go past our first 3 topics that we've been working on 4th quarter and having that start to spread to the other departments within the organization so that they get excited as I am.
Ed Miller, Action Health Partners. I'm a squeaky wheel. Clinical community linkage, connecting to the community programs that are out there.
I'm Amelia Davis with Coordinated Care, one of the managers for external relations, and I'm new to the North Central ACH. And so what I would like is for you guys to be able to see more consistency with Coordinated Care, with me being here at the meetings.
Jill Thompson, Lake Chelan Community Hospital and Clinics. I'm kind of just back on what we're doing. It's exciting what we're doing and just moving forward with our population health initiatives. I'm just excited about those.
Rosalinda Kibbe, Columbia Basin Family Medicine in Detroit. And I think we definitely want to see some simplification. This time of forming has been hard, and being able to actually know what we're moving forward in is exciting to us. So I want to see progress as well.
Blake Edwards, Columbia Valley Community Health. I'll start the year with the Serenity Prayer, which is, that we would have the courage to change what we can, the peace to accept what we cannot, and the wisdom to know the difference.
And that's hard.
Good morning, Courtney Ward with AmeriGroup. I think I just echo the data sentiments that have already been stated. It would be really great either from the states to get a baseline or, set metrics, or for us as MCOs to work collaboratively to come up and maybe establish those for the region based on what we can for you all.
I'm Kathleen O'Connor from Cascade Medical up in Leavenworth, and I, along with everyone else, the data issue is important to us. I just really like to see some alignment from all the different organizations, all the different people that are asking for data from us, whether it's medical home or whatever, so that we're looking at the same thing across the line and don't have to tweak each little thing to fit particular data reporting requirements.
My name's Paul Hadley from the Center for Alcohol and Drug Treatment. The data thing, trying to get all the data for all the stuff we said we were going to do. When you come down to look at how you're going to get that stuff, that's when it's like, oh, okay, that's what they meant by that. Okay. So the 2019 plan is considerably different from all the coaching we were able to get. So one thing I'd like to see us be able to accomplish is get our facility physician so we can start that piece.
Mm-hmm. Loretta Stover from the Center for Alcohol and Drug Treatment, and one of the goals for 2019 that I'd like to see met is having a medical provider within the center to be able to assist with our withdrawal management and intensive inpatient program.
I'm Gail Goodwin with Grant Integrated Services, and I'm excited about getting more staff involved. We've had a pretty small team that's worked really hard, and we've just started really trying to get information out to staff, and they're excited. So I'm excited about being able to move that out more agency-wide.
Tessa Timmons, Confluence Health. And I think I'm going to echo what Michael said, and just making sure that we continue to build our relationships with our community partners. I think recently we've had some challenges, and I think some of those relationships have been a little tested, and I think we can get through that. We can continue to grow and become stronger and realize that we're all on the same team serving the same patients.
Dave Coldy, Confluence. I'm looking to have some more collaborative relationships moving forward. So I'm going to be heading up to Cascade here in a week. So.
Holly Zwanek, Children's Home Society. On the data end of it, we're looking forward to getting pre-manage up and running so we can have an idea of where our clients are and what their needs are and responding to those. And we're beginning a needs assessment in-house for a company-wide new EHR system. So that's going to help with a lot of data collection and when we have the value-based payments come online. So.
And I'm Roger Chaffrenier, part of the consulting team supporting your initiative. My hope for this year is to be able to support all of you in a learning intervention that creates wow results for something that's important to you.
Shirley Dilbert, Catholic Charities. My goal is to figure out how to train staff to integrate physical health along with behavioral health on the same treatment plan.
Rachel?
Good morning, Rachel Petro, Strategic Solutions. I'm
I would love to see more collaboration within and among this group. It's growing, but that would be my goal.
Montana, you can introduce yourself. And
I'm Montana. I am with the Department of Health and Practice Facilitator for North Central. I've replaced Tom Thompson, if any of you worked with her in the past. That's me now. And I am really looking forward to seeing bidirectional on a strong path that's already on in this ACH and to continue to be a model, I think, for other regions.
Paige Bartholomew, also new with Action Health Partners. I'll echo what Ted said, looking for more community clinical linkages as well as interested.
Welcome.
Hi, I'm Tanya Gleason with NCCH. I'm looking forward to continuing to collaborate with partners on how to best address and kind of my own understanding of the gaps in.
I'm Chapman, NCACH, and I'll be interested to see how the transition to version and acute care provider stuff interact with the 2019.
So I'm North Central ACH, and I have a similar goal is to formalize how our opioid project and collaborative are working. Sahara Subal, North Central ACH, a conglomeration of all of the things, but I think this year in particular, as we enter the third year of the transformation, really excited to see not just the collaborative, but our other work groups and our coalitions for health improvement continue to find ways to really synergize and make all of this work come together and coalesce in a way that we are of this community clinical linkages. I'm Teresa Davis with the North Central ACH.
We don't mess with Teresa. We'll let that one go. And now let's go on the phone. Anyone want to go first?
This is Sheila Chilson from Moses Lake Community Health, and I'm looking forward to working more with Grant Integrated on our change plan activities. I will just throw one more thing in, that I'd love it if we could use the technology so that all of us joining remotely could use video, and that the quality of the remote participation could be better.
Good point, Sheila.
Hi, this is Kendra from Catholic Charities, and I'm new to Washington, new to the position, so I'm just looking forward to getting to know everybody and delving deeper into this work.
Welcome, Kendra.
Hey, this is Christina Clark from the consulting team from CCMI. One thing I'd love to see accomplished by the end of the year is to have some improvement data over time that gives us an indication of progress towards the aims that are defined in our change plans. And lots of smiles by the end of the year. That's two things.
Hi, this is Laurel from Molina, and I'm not with you, saving you from my cold today, but I'm excited to work alongside all of our partners to advance population health and also to collaborate around data and shared workflows.
And this is Vicki Evans from Molina Healthcare. I would agree with what Laurel just said, and I'm also really interested in hearing what the experience of providers is, as well as their perceptions of our members and their experience of care as we start to make changes in the way we care for the population.
This is Jim Novelli from Okanagan Behavioral Health Care. Hoping to continue our collaborative efforts and to enhance our services throughout the county and expand, especially our telepsych, which we're getting ready to increase our psychiatric coverages in the county. And I'd like to see ongoing good learning activities that the Whole Person Care Collaborative can help put on the table.
Christina Harville, Columbia Basin Family Medicine. I'm looking forward to streamlining our data and mostly improving our data through the year.
This is Gwen Cox from Qualis Health, and I'm looking forward to seeing you guys continue to be a welcoming place for all providers, and that your data can serve your needs. And like Christina said, we have a trail to show improvement over the year.
Kathy Grimes with this consulting team, and I'm looking forward to seeing improvement, watching your collaborations actually give you some traction, and really seeing that your hard work is paying off. And by the end of the year, I also hope that your citizens begin to notice your hard work and are increasingly engaged in the process to improve wellness in the region.
This is Shoshana Palmatier, Cooley Medical Center. I think one of our goals is to, we're working towards finding a new EMR system that'll be able to help us extract data better. Also increase our collaboration efforts with our local clinics in our area, and also behavioral health.
This is Dulcie Field from Columbia Basin Health Association. Just looking for improved collaboration among the group and hopefully better clinical outcomes for our patients.
This is Stephanie Dowland from Moses Lake Community Health, and I am really looking forward to operationalizing some of our plan for 2019.
So this is Richard from Samaritan Hospital, or Samaritan Healthcare in Moses Lake. We're really hoping this year to be able to tell our story of our journey towards whole person-centered care through the drivers and the aims and our metrics. And yeah, we also hope to kind of gain traction with our teams to work on a lot of our initiatives within whole person-centered care, and then also as they relate to other projects that we have coming up this year, including a new EMR system and becoming an ACO.
Hello, this is Courtney from the Children's Home Society, and one thing I'm hoping to see this year is improved collaboration between the physical health and the behavioral health organizations.
Hi, this is Peter Morgan from the North Central ACH, and I'm looking forward to continuing improvement in our learning activities and enthusiasm and participation and collaboration among the parties.
Anyone else? All the organizations checked off, but are there other individuals that want to say they're on the line and not ghost us? Okay. I was enlightened. I like two of the things that I really heard, and you probably heard as well, was data and collaboration. So over and over and over again. So I'm really excited. And Caroline, my co-pilot, as I called her, took notes for me. Thank you. I wasn't expecting that. So we'll revisit that in December and we'll see how far we come. So let's go on. You guys have the agenda in front of you. Can I have a motion to approve it?
Second.
Motion by Chris, Mr. Chris, and a second by Jill. All in favor?
Aye.
All opposed? Motion passed. You also have the minutes in front of you. Can I have a motion to approve the minutes? You've had a chance to review them. Melody motions. Second. David seconds. All in favor?
Aye.
All opposed? Great. So a few follow-up things from December. We talked about the WSU mobile needs assessment. I did have an email conversation with Dr. Min because he was not able to come to January's meeting, but he will come in February. He has hospital duty until noon, so he's going to record a quick presentation and then be available at 12:15 to be able to answer questions. We felt like that would be the best use of time, so he can give you the data as he's presented to the board, and then you guys will be able to ask questions of him for further clarification. Coaching update, we're calling them practice facilitators. We have some promising applicants, so hopefully I'll have some more information for you at the February meeting. Quarterly reporting, I've heard from several of you. I'll reiterate, this is going to be a messy process getting started as we are all learning. So just kind of bear with us on both ends. And you will find that there are measures in there that may not be yours. We are working on those. Please let me know. There will be measures in there that you say, we cannot report on this because we can't pull the data, or we cannot report on it in the format that it is. If you can't report on it in the format that it is, can you just send me your data? That's going to be the easiest fix at the moment before Friday. So if you have it in another way, just send it to me, and we'll make sure that that's documented that way. If you're not able to report on it because you can't pull it out of your EHR or you've changed it completely, just note that in your barriers and next steps. But just make a note of it so we know where you're at and that you thought about it and you just haven't skipped over it. I've put up there where it's at. You're all familiar with the portal by now. There's the change plan in the measure documents. There's two types. You're going to do your change status. You're just basically started, not started, your successes, barriers, and next steps, and any kind of TA that you have received. And then there's the measure data, just the actual numbers. Please remember when you get to the measure reporting that there are timeframes that we have set out. I've outlined it here. It's on that first page before you enter that reporting portal. We would like everyone submitting data in the same time period so we can compare across the collaborative. Can be a painful process. Reach out to me. Don't stress. Don't. Just call me. We understand it's a messy process. Just communicate is what we're trying to say. You have my email. Reach out, email, call. I will return as quick as I can if I don't pick up the first time. If you haven't gotten into the reporting portal, there are a video and a PowerPoint tutorials. You can just go in. I've outlined where it's at under general resources. There's a specific folder for portal tutorials, and they're both listed in there for your convenience. Change plans that were due 21st of December. Just want to give you an update of where we're at. The initial scores will be released on the 15th. If you are not happy with your score, there is a 2-week write-back period. You are more than welcome. If you're not happy or you have a question about the comments, reach out to me once again. Talk to me. You have 2 weeks to make any changes that you would like to be made. You'll resubmit those on January 31st. We will rescore those and have those back to you by February 15th. Any questions on the reporting or change plan? Okay, just want to go over payment. We've actually had a couple questions. Just remember that your base amount was calculated according to Medicaid counters. When those numbers come out, we will compare to what we've already told you and recalculate if necessary. It's also a percentage of your change plan points. So remember, you are being graded. It was a pass-fail last time. It's being graded this time. So if you don't get that 90% for maximum funding, take advantage of that write-back period. So after you've reported January 10th, you will receive the full funding of that. Q4 is not based on change plan scores, is what I'm trying to say. So you can take your, if you're getting 65,000, you can plan on 16,250 as long as you're reporting. It will be that Q1 report once it's submitted at the end of March that will then be calculated on change plan scores. Does that make sense? Any questions? Okay. Learning activities, quick update. Just wanted to follow up. The behavioral health into primary care land had 57 individuals, 11 organizations. We averaged about 29 individuals per call, which I think was great participation. Some of the highlights was the content was directly related to the change plan and the team collaboration. Not always just what was happening around the table, but was happening between organizations talking to each other. Several people noted they liked hearing the successes as well as the missteps of other organizations. One, you feel like you're not in it alone, but two, you can learn from them as well. Some of the improvements was some of the logistics of the breakout sessions could have been better. It was a little clunky, and so some process improvements that we'll be working on. They did breakout sessions in the primary care land that they would like the continuity between them. So every breakout session you're meeting with the same organization. It wasn't split up. So you kind of develop relationships. And you have a little more trust sharing. And then giving participants questions ahead of time that you'd be asking, so it'd be more thoughtful responses. Behavioral health land, there were 47 individuals total, 7 organizations, and about 26 individuals per land that participated at another great participation rate. They stated the introduction and creation of new tools and processes was very helpful, and again, the team collaboration. Improvements, they would have liked more rural health examples given. They were a bit too long. A couple people said that would have been better if it was an hour. Some individuals said they wish there was more sessions after the PDSA cycles, and then a better understanding of that the faculty would have a better understanding of where the participants are, so they knew within their integration process so that they could address that. Okay, what do we have coming up? We have the empanelment going on right now. It's on Fridays from 12 to 1. We have 7 organizations participating in that. We have a Foundations of Motivational Interviewing come up. We've done 2 of these. We're going to do 2 more. The next one will be February 14th and 15th at Samaritan Hospital in Moses Lake, and then we'll do another one in March and April in Okanagan County. That location will be determined. We will be doing a train the trainer a little bit later, so if there's individuals that you think would be good trainers, please send them to this initial one if they haven't already gone through it. We have an introduction to quality improvement. We also did the 2 of those. There's still questions, and we've decided to do a virtual one on this one so that break down some of the barriers of travel and the time commitment of 2 days. So this will go 3 consecutive Tuesdays from 12 to 1:30. They will be videoed and available in the portal eventually. I'm not going to tell you when, because then you may not sign up, but maybe next year. I'm just kidding. We do want those who are involved in your quality improvement process, it's a good workshop to send them through so they really understand the language and what you're trying to do, and will help bring them along as you start implementing your change plan. And again, we do have the QI Affinity Group going on. The next time it meets is January 2nd from 12 to 1, January 22nd, excuse me, from 12 to 1. And we'll be talking about setting up a QI team. So if you're interested in that, please join us. It's open to anyone. So I've kind of rushed through those really quick because caught us up after our introduction section. But as you know, I took over from Peter, and I had he told me I had 90 days before to get caught up to speed, and after 60, he left me. So Peter's on the line and can hear me. He actually took off, and so no hard feelings, Peter. So I've lassoed him back in, and we're going to keep him as part of the WPCC. So I'm going to try to turn it over to him to see, let him talk about what his continued role in the WPCC is going to be.
Well, Wendy, thank you. Thank you for the introduction. And, you know, I gave you 60 days because you're such a quick study. It would have been a waste of time for me to hang around longer. But, yeah, Wendy and I have talked, and Linda and I have talked, and I would like to stay involved in some way, shape, or form. And I know that there are a number of interests that have been expressed around things like access, you know, management of contact centers, which would involve appointing and would overlap with access, but might also involve nurse advice and other things. So this is for organizations that maybe have, you know, multiple sites and are looking at centralizing a lot of the contacts. And then finally, I would like to continue to follow up on the 24/7 nurse advice idea that we surfaced maybe a year ago, and it got kind of put on the back shelf. So I'd like to finish off that work and see whether we have a viable idea there. And on access, I would work with or for Roger and Kathy and Tina and others. They're really putting this together, but to the extent that I have contacts and ideas and help hone the learning activities and some of the content there, I would offer my help in doing that. So that is it in a nutshell.
Discussion around the table, thought? What would you like to see? Here's your time, he's available. Speak up for what you want. Okay, we'll just work together. I think we'll probably start looking at that contact center. That would be the first thing that we'll start looking at. Get more information on that.
Hey, Wendy, this is Laurel. Could you just say a couple words about what the contact center would be? That's not familiar to me.
Peter, can I let you take this one?
Yeah, I think organizations, particularly larger organizations, have done things like centralizing appointing. There are any number of other things now that can be done remotely, including nurse advice, telemedicine, and so the whole of an integrated contact center where it's sort of a one-stop shop for patients or members who are looking to interface with an organization around care. So as we all know, there's a lot of things that can be done without a face-to-face visit, obviously done carefully and with a lot of forethought, but that's the idea. And we're moving beyond the term call center and into contact centers. And this, I think, would be particularly useful in a rural environment where travel time is a challenge, and there may be other ways for people to get care. Roger, I don't know if you want to comment involved, or David or others that are thinking about doing some of this work.
I know if David has any comments, and you have a lot of interest in contact centers.
We have interest for sure, because we have a contact center that is functioning at its optimal capacity.
Share my phone. Sorry.
Yes, we have interest in it. We have a contact center that we don't feel is operating at its idyllic. So.
Just a couple of observations very quickly. When you call Marriott in Orlando and ask to book a room, that's not done by Marriott, that's done by Expedia. And they found it much more cost effective to centralize it and outsource that service than to do it on their own. So the notion is to collaborate on setting up something that disperses the cost and maximizes the efficiencies and the technology in a centralized way. There were 13 factories in Massachusetts, in Malden, Massachusetts, that could not afford consulting and training and HR services, so they banded together to form something called GOAL, the Greater Organizational Alliance of Lowell, Massachusetts. And that ended up becoming a rather large company that ended up developing all sorts of quality improvement tools and other mechanisms, but lowered the cost of those shared services across all the parties. So I think that's the notion. Is there an opportunity here, either a nurse advice or a contact center, something that you could pool resources that would lower your cost and maximize the efficiency while allowing you to have your own branding and autonomy where possible?
Any other questions, feedback? Anyone on the line have anything they'd like to add? Okay. that is all I had for the business portion of the WPCC. I will turn it over to Roger, who's going to continue in our leadership series.
Great. Happy New Year, everybody. Welcome again. Let's create a little bit of a breadcrumb trail from last fall, because we do have a little bit of holiday brain left over for many of us, certainly myself. We launched this leadership series in the fall, recognizing that in collaborations, one of the critical success factors is leadership and the ability to lead and make change in the organization. You have such a unique opportunity here, having all the organizations working together and collaborating, and to have some resource support outside from the region. And the question is how to really translate that and accelerate that. So we decided to do some small tutorials on some areas where there's opportunity to share information, share some new content perhaps, and some best practices, and then put also energy into translation into practice, moving from theory to practice. So today I'm not going to introduce any new concepts, but see if we can take a little time and process what we've talked about in the fall, and then move our attention to what you want to work on over the next 6 months, beginning with the dialogue with asthma and cardiovascular disease. So in the fall, we introduced these concepts and used them as part of the teaching, beginning, and they're not necessarily in this order, but there's a logic to this information. Understanding that you're trying to make change, that it starts with understanding how individuals are motivated and keeping those key principles in mind. So we focused on intrinsic motivation, saying that you have to really understand that intrinsic motivation is something that's going to sustain over time. And that is tied to a couple of key variables. One of them is the ability to control the variables around you, not have things suddenly just imposed on you, have some input. It's a really important design principle in thinking about change. With the last session, we introduced a whole series of different change models, different approaches that people talk about change. They have common themes. In trying to move change along, you have to start to first plan it, to prepare the environment for the change. That's what they call unfreezing people. Otherwise, people are going to resist change if they don't understand the why, if they don't understand answer the question of, well, what's this going to do to me? How's this going to affect my world? How's this in my best interest to move forward? You then have to provide people with the tools and mechanisms for change. You can't just cry wolf and say change, change, change. That's like telling providers in the clinical setting, you got to improve your productivity, and all you're doing is frustrating them because you're not giving them the methods or tools to be able to do that. You're not changing the systems that enable productivity and improve. Once you make those changes, you then have to reinforce them. You have to make it very difficult to go back to the old way. So really thinking about how are we planning change, how are we being very deliberate. We also talked about in the fall specifically about quality improvement, what's really involved from a leadership perspective. How do we engage our patients and families in really understanding what are the needs and the changes we're trying to develop? Translating that into some design specifications is something we can implement, whether that's waiting time or cycle time or getting access or whatever it may be. Also, how do we set up projects so that they can succeed? Do we have the right people at the table that are working on the improvement efforts? Do we have really thought through the scaling up and sustaining this over time? Once we start that process, we need to have some good measurement to know how we're making a change. So we have to have that quality control piece in place and make sure that that quality control is there for the long term after we make the changes. And then there's the whole series of quality improvement methods of how do we go about improving change, what mechanisms, what change models can we use. So whether you're using Lean or PDSA or Lean Sigma or all the different labels that are out there, those are all methodologies to pull people together to how to make change. And then once we've made change and we want to really scale it up, we've got to remember that that's a social process. It's not just about sending a memo out on the new change, but it's about how are we engaging people and enrolling them in that new change. So paying attention to who are the early adopters, trying to get them on board first, and then scaling that and pushing it through so that we aren't held hostage in the end by those that are pushing back in the laggards, and we can move the agenda forward. So that's all great theory. How does that apply to practice? What are some of the challenges you have in terms of applying this theory to practice? I have a couple of vignettes to share if you don't have any. So, Chris, it sounds like you have one right off the bat.
Oh my God. Well, a good example is from December 31st to January 1st, we lost 5 beds at Eastern State. There was no communication about why. So we're struggling with the data piece. So it makes it difficult to communicate data to our staff when the goal keeps moving. So I don't know if anybody else is having similar issues.
So extrinsic forces suddenly imposed on you, out of context. And so you're a classic example of what happens when that is not executed well. And you're put in the position now of having to translate that for your staff.
Right.
So what could be done to help with that translation?
Would have been good to hear about it beforehand.
Right. So engaging whoever the sponsors or stakeholders of that initiative to, make them aware of what the impact is on your role and the cascading effect. Yeah. What else? What else could be done?
Create a culture of safety. I mean, you see fear and external stimuli affecting change on both sides, and really those are the same kind of thing. Fear is a stimuli.
Yeah.
So if you have that culture of safety, not just in patient care, but in the interactions and the jurisdictions and the authorities that you're dealing with in your facility, and people are free to make, suggestions or self-report or come up with ideas that might be kind of out of the box that they wouldn't have otherwise suggested. So that sense of belonging and safety for everyone is important.
So there's 2 aspects of what you said. There's the internal piece of creating a safe culture in your organization. So as changes come along, people have a sense of trust. They trust you in what you're saying and where we're going. It's not just random change. Same time, in terms of those external stakeholders, then giving them a sense of what the impact of that is on creating a toxic culture. How this has a cascading effect on the workforce, then in turn the patients.
Right, you lose 5 beds, then you say, okay, how many FTEs am I going to also lose? Who's going to pay this loss of revenue? And what it does, it stimulates all kinds of responses that you don't always prepare yourself for.
Okay. Other examples of challenges of really implementing the changes that you're trying to make here with your change plans and all the work that you're doing within this collaborative. Where are you struggling?
Anyone on the phone?
Yeah, it's Richard at Samaritan. So one of the struggles we're having is we have other projects outside of the ACH, including the ACO and the Grand County Hospital Alliance, that they have similar initiatives like transitional care and some other elements that sort of flow through what we're trying to do here as well. And they have particular needs to be addressed too. So we are looking to see if we can come up with one design that meets the needs of several customers, which is, it's proving overwhelming because when we look at it, we have these 3 huge projects, but then it actually complicates things a bit when they start intermingling with each other, trying to figure out, does this work with something else? And if so, how do we make it work for everyone? So it's a bit, that's a complexity that we're just running into this year.
So the challenge you're articulating is the multiple competing priorities, where you have different initiatives either voluntarily signed up for or imposed on you. And that can be a patient-centered medical home or health home initiative by one group of stakeholders. It could be a value-based reimbursement incentive program by another group. There's the work of this collaborative, and they all seem to be separate projects in people's eyes. So what are the implications of that? What could be done from a leadership perspective to make sense of all of what Richard is trying to do at Samaritan? Thoughts of the group? Have any of you had an opportunity to map out what, at a base level, what is the initiative? What is the aim of the initiative? And where are there, what has to be executed for that initiative? And then where are there overlaps or intersects with all of your work? So for example, we've heard often that Joint Commission or accreditation often can become a competing priority. There's an upcoming site visit coming to an organization. So, oh, we don't have time for this, Joint Commission's coming, or URAC, or whoever your accrediting body is. But most of those accrediting bodies are looking for examples of tangible quality improvement initiatives that you've done. So your work here could be, in effect, a case study for helping you get through some of the accreditation challenges. That's an example of an alignment where you're choosing to use this as a opportunity as opposed to launching a whole new set of internal quality improvement initiatives. Other thoughts? How do you, yes?
I think finding that shared benefit, if you can dig down until you find what the common outcome for each person might be. There's lots of ways to translate some of these varying regulations that we have to follow. Like I said earlier, that lining those things up is important to us so that we don't have to do one thing 3 different ways in order to achieve the outcomes that we're expected to achieve. So you find those that have a shared outcome in mind and find what's common at the ground level and start with that. You know, that climbing Everest or climbing the whole neighborhood hill all starts with one step. So if you can work from there, it helps. So that's what I've kind of worked with our group, is that people will dive in if they know helping so-and-so is going to get me my piece as well. Then it kind of forces people to collaborate.
So helping people understand where the synergies are and engaging in them, okay? Mm-hmm. Other thoughts?
Could be a labeling thing. Mm-hmm. This is the ACO project. This is the NCH project. This is the whatever project. If again, it gets down to the basics. What's the aim? And you look at the project, put it forth as, okay, we're doing social determinants of health. That's needed across everybody. It's a synergistic. Rather than saying that's the Medicaid one. It gets people confused. Now, do I do that on this patient or that patient? No, we do it on all our patients.
So maybe the other initiatives become part of your change plan. They are part of your execution strategies if they align with what the overall aims of the WPCC. So you're creating it as one and helping people understand that, rather than launching separate project teams to work on things when in the end it may be very similar type of work. Other thoughts?
One of the things that has had a really good impact on the Family Health Centers team too is that emphasis on our aims, saying what are we trying to accomplish for our patient. It's not about the initiative, it's not about quality report. And being able to start with that and having our administration kind of shift where their direction is it's not about meeting a measure, and our quality isn't, our quality improvement program isn't about meeting measures. It's about what are we wanting to accomplish for our patients, and then building our quality improvement plan about that, so that that's the focus as opposed to a report or an initiative is the focus, has been huge for us.
Really aligning the aims around your core really important outcomes for your patients and for your organization, and not just around the funding initiative. And that's where there's an opportunity to potentially align multiple activities.
I think that shift has made the difference between having our staff kind of roll their eyes and say, oh great, we get another project we're responsible for, as opposed to this is really changing our overall service to our patients, and that has value to them, whereas they don't care a bit about the next pet project that we have picked.
Yeah, the flavor of the month project.
Flavor of the month, exactly.
Okay. Any other thoughts? Have any of you been able to commit euthanasia? Get rid of projects. So you look at your organization, here comes another project, and now we're going to do all this work for WPCC. But we have these 20 other projects we've been working on for 4 years now, And we're actually not really getting anywhere with those efforts. Is there an opportunity to kill them and start all over and say, you know, we're not making progress, let's just stop. And let's recalibrate and put those resources to some other things that might be more contemporary, more important. Do any of you envision any projects like that in your organization? Chris is giving me a wink over here. Yeah, I've got a couple.
Well, I would say for us, not necessarily a project, but more a process or the way we've done business that we keep doing that is sort of maybe more bulky or more involved or doesn't get us where we need to go. So we've always done it this way because we were going here, but now we need to go here. So how do we kill this process and figure out how to go here? So I don't know. Now I would say that I have been in meetings where the resounding cry from everyone has been, do not say yes to one more project, Gail. So I think knowing that too, knowing that you've reached your maximum and that you have to pare things down, I think is important. But I don't feel like we have a project that's not working, but I do know that we have processes or the way we do business that isn't going to get us where we need to go for our change plan and some of the other initiatives that we have committed to.
So what might you do to identify those opportunities and execute on them as leaders? What you've got?
One of the things we're doing is going to teams and saying, I mean, sort of your euthanasia, like, what are you doing that you don't think is of value? And then what are you doing that is of value and we've also, we have people, and I would say one of our biggest challenges is having 7 locations and trying to figure out how to keep it small enough to be able to handle it, but being respectful that we have staff and clients all over Grant County. So I think some of that about, oh, you do it this way in Quincy and you do it this way in Freda. And so I think some of that, identifying what is a good process or what is the current process and how it is that. So we've started talking to teams and saying, especially we started with the front desk and we've done workflows.
Great. I think there's also an ownership by leadership. One of the big contradictions we face is that on one hand, we're told generate widgets, but then on the other hand, show outcomes. So I tell staff outcomes, and ultimately it's going to be leadership that owns that. And that we have to make the move towards outcome-based services and own that if we fail at this, that ultimately it's mine or Chris or Shirley's responsibility, mine, because that's what we tell people they have to do. So that's, I don't know, I'm fearful of that, but I also think it's the right thing.
So being disciplined as a leader in terms of reaching out and minding those opportunities and then prioritizing them to leave time and bandwidth to work on what's really important. And hopefully bring some joy back into work, because when people work in mindless tasks and workflows, it just adds to the grief and frustration and contributes to the turnover and other issues. So as leaders, we've got to say, okay, let's get rid of the insanity. What data elements are we collecting automatically that nobody's using? Just get rid of them. They're not being used and not required by law. Check on that. Get rid of them. We just take them for granted. Oh, we have to do that for the state. Oh, we have to do that. When you actually do your homework, urban myths with a lot of them. So identify those urban myths and get rid of them. There are a lot that are mandated and you have to do, but focus on where you can make opportunities. Ask the staff. Where are we wasting our time and energy? Where are you wasting your time and energy? And then prioritize how can we use that and create some bandwidth to work on what's really important, which you've just suggested in terms of those alignments. So you put something on the table about scaling and standardizing. Really tough challenge in systems and organizations. So based on some of the concepts that we introduced before, if you wanted to scale a best practice you identified in one of your clinics, that people said this has been a waste of time and enables you to get rid of a bunch of unnecessary workflow, and you think this is the best practice, how can you scale that across your multiple sites? I think you said 7 sites. How can you scale that across 7 sites? What would you need to do as a leader to tee that up to be effective? That's a challenge to the group. If you were in her shoes, that's in her shoes. So what would you do? What would you do to try to address this across 7 different sites with X number of providers and care teams? How would you, where do you start? What do you need to, what's the starting point?
I think you need champions at each of the site to come to the good site to see how it's done, and then use those champions to spread the.
Okay, so those early adopters, where are the early adopters in each of those sites that you might be able to start with in terms of the new practice? Well, what about that intrinsic motivation piece? What do you need to do to unfreeze and get people ready before you even start to make the change? All right, remember, if all of a sudden you don't want to have the people coming plopping it on me, here we go again, the other flavor of the month, right? Unless we're going to resist it.
Explain the why.
The why. So we got to get back to the why. Why, you know, why are we making this change? What is the intent? How does this connect to our patients? How does this connect to your quality of work life? Why are we doing this and going through this pain? Why now? Why is this sense of urgency now? Answering all those why questions to get them on board.
Ask questions and really answer them.
Okay. So tease out of them their pain points and listen, and then this becomes a partial answer to some of their pain points. So they see the dots being connected.
That's the first step to their engagement. Power them all you want, but if they don't buy into it.
Okay, so let's assume that you've done a great job of getting the why, and people are now begging for it. Say, okay, I'm ready. You know, bring it on. What do you need to do next? They're asking you to make a change, but they're like, okay, what do you want me to do? What do you need to do? You need to really work on the workflow. You got to package the change. You can't just say go do it, right? You got to put the materials together. What's the change package that you're giving people to be able to be actionable, right? You want me to do this new workflow? Who does what and when and how are we going to measure it? How are we going to standardize it? How can we make sure that it's working the way it was designed? What's the quality control piece that we're going to make sure that it's executing? What else?
I know that if people have buy-in, I know somebody said take them to the good clinic and show them how it's done. My belief is that if everybody has some input, what do you think about this, and getting everyone's input, there's more chance of follow through down the road because it's their plan, not something done to them.
So getting the people who've actually been successful in executing then as those new champions to work with their peers and show how it can be done, and they can see the tangible advantages, and they can answer some of the questions of what was the impact in reality on your daily work life, and how's this really affecting the patient from that perspective. That makes it much more real and buy into. Any other thoughts?
This is Sheila in Moses Lake. I would just say the thing that we've learned in managing multiple sites is even though as leaders we strive for consistency, that it's really important for each site to have their own style, and before engaging in a change process to just realize that there are uniquenesses within each site that needs to be allowed for.
Identify barriers and maybe go to that site that's really the loser and find out why. You know?
Tell us about the loser again.
Well, because I think people in the one place that's having trouble, they do feel like losers. What's the point of trying? I'm working my tail off and nothing's happening and I just can't seem to do what you're doing. And so, you know, maybe they need to be brought to the forefront and look at what's wrong. Why is it that way for you? And make them feel heard. And then, I mean, it's like the person in the office that nobody likes. Once you get to be friends with that person, they're your best ally because you're the only person that paid attention to what their needs or what their problems were. And maybe they'll come out being the shining star because they felt heard. Hours.
Okay. So really understanding some of the local challenges and the context of that area. Maybe there's some different nuances that are a repeating barrier.
And you can't assume what you're going to find. Because you might think you know everything about managing a group of people, but there's always something that you find.
So while working with those laggards and understanding their context, we're not going to hold that as barrier to progress. We're going to continue to work with those other early adopters and execute. And through our execution strategies, hoping to bring them along so that they see the benefits, but also adjusting our strategy as need be to that local environment. It could be a different population, different labor force, could be lots of issues that we have to contend with, that we have to overcome, that we may make too many assumptions in terms of our execution, that we have to do our homework.
So Roger.
Yes?
I'd like to ask a question of Sheila on the phone. Sheila, could you describe an example of what you meant by the uniqueness of each site?
It can come down just to how the clinic is laid out. For example, we've got a process in Moses Lake for doing pre-visit planning that doesn't necessarily work well in Quincy. Now, I don't know if that's a true example or not, but just in how a provider's office, where their staff is located as compared to their exam room, just because we do it one way in one clinic doesn't mean it's going to work in another clinic because of the physical attributes of the clinic. Or more specifically, maybe something with the patient population might be different as well.
Yes.
A good example of that is in some of the clinics for family health centers, we may have up to 80% of our patients who prefer to speak in Spanish. Mm-hmm. And if you have a provider who speaks no Spanish and it requires a translator, then it completely changes the needs of your staff support. Where if you have a larger clinic where your providers speak Spanish, but the demand is lower, and you also have more people who translate, completely different circumstance. Even though your FTE to provider ratio may be exactly the same, it completely changes it based on just the population needs for language issues.
And we deal with this all the time. I mean, it's unique across every one of our sites, and what it really is you may develop, everybody buys into what the goal and what the why is, but you develop a best practice, and then you PDSA it to death, and then you take it out to the different groups, and and they're not going to buy into it if it doesn't work for them. You've got to allow for variation, because it may not just be, as Sheila says, every clinic's different layout, but you also have different staff too, and you may be staffed completely differently in some sites. Some sites have RNs, some sites have MAs, and so buy-in is much better if you allow for that variation. Still got a common goal.
Well, this has been great dialogue. I can encourage you to continue to think about the concepts that we talked about and plan for the change. Don't just take it for granted. Don't just send out the memo, but really be deliberate in the planning. Next month, what we propose talking about is senior leaders' role in monitoring improvement projects. How do you engage the team? How do you ensure that it's being executed the way, and that things are progressing, and that you're optimizing your role as a sponsor and senior leader? So that's a proposed topic for next month. What I'd like to do now is shift into another why, and that is talking about what you'd like to work on as a group as we move forward here in 2019. We started with a dialogue on asthma in the fall and collecting data. Some progress has been made on data collection with many of you, and we'll begin to talk about that in a second. But I'm going to challenge you, is this something you really want to work on moving forward as a group? Heard from some people that asthma doesn't necessarily fully align with their local priorities, and so that's something we want to challenge. And if it's not something that is universal, then perhaps that's not the right thing to work on. But if it's not, what is? What would be a common element that we'd want to focus on? CVD is an opportunity we raised for a sprint. We had an informational call with inviting a group of people. I do not think we have critical mass at this time to do it. We've gotten several people come back to us, said this is an interest, but the timing's really bad right now because of some of those competing priorities we just heard about. And let's put this off until later in the year. So we're not abandoning it, but I would suggest that we push that further on. But I'd like to come back to the table and ask you, is there a topic where we could pull group together and do a sprint to really generate results in the near term. So let me start with asthma, and let's see, we challenge you to have any reflections on your asthma data. In thinking about the asthma data, some of you have come prepared to share today, and others are still working on your data. There has been some good engagement with the payers who've expressed an interest in supporting. Some has provided some initial data. We're not sharing any of that data other than I'm going to show you a blinded map just to give you a sense of some of the data. But in looking at the data, we were looking at this from a population level. What we want to see is, are there any geographic concentrations that give us an opportunity to perhaps focus energy and resources? Instead of trying to do the whole 4 county areas, there's specific locations that might be lend themselves. Are there any patient segments that represent a subset that might be manageable to go after that we can think about? Are there any process or issues or workflows that are something might be manageable? For example, one of the indicators on your list is shared care plans for children. That's a very specific process that could be tackled if you decided you want to do that as a group. That's something that could be tackled, and you could probably move the numbers pretty quickly by organizing that and really executing. So those are examples. Again, thinking about the so what in terms of these geographic, just 2 examples, and I'm probably repeating myself. An example in New York City with Paloma Hernandez and her group did a geocoding and found that there was a whole group of blocks of children that lived on these blocks that had asthma. And when they went and looked at the data, it was right next to a big trucking terminal where trucks are coming every day and blowing out the exhaust into the streets as the kids walked to work to the elementary school a couple blocks away. So they went to the trucking company and got them to turn off the engines, and the asthma rates went down. That's something that's very actionable, there's focus, something they could do, and it wasn't a high-cost intervention. But they wouldn't have known about that unless they used their data to target it. Jeff Brenner and the Camden, that started the whole hotspotting phenomena that's been written about and spoken often in lectures around the country. Found in Camden a couple housing units where the high cluster of kids with asthma, and turned out it was mold in the buildings. So they were able to go in there and intervene with the mold and improve the issues, reduce the hospitalizations and emergency admissions for the kids. So that's what we're looking for and trying to see the data. I'm going to move forward real quick before, sorry, let me go back here. One of the data sets we found is from the state was that here in the region, the state, you have a much higher incidence in African Americans compared to other population. And you have a relatively low population of African Americans in this region. So it's interesting. And does that represent an opportunity? Don't know, but something to discuss. And the same thing looking at potentially with children. The data for children was not available here in Washington State. The data from the state and this is somewhat old data, showed that Okanagan had a higher in Douglas versus Chelan and Grant in terms of just the incidence and prevalence of asthma in the area. So any of those that have brought data, any data you're willing to share or inform the group, any insights? I think we heard from Samaritan last month that presented some data, but anybody else have any data you want to share with the group? Any other insights? Data. Hold on a second. Data just walked in. Okay.
Data.
Yeah. You got any data? This is on asthma.
I heard asthma.
Yeah. This is relative to your population of patients with asthma. Any insights or data, observations, any learnings from looking at your population of patients? Does it break down into any segments, geography, anything that might be helpful?
I don't have those numbers.
Okay.
But they are in the system. So now that I know that, we can get some data. Sorry. I know.
No worries.
Roger, I just want to say that Molina, Mara Group, and Coordinated Care, and we've had a conversation over the last 6 weeks, really coming together to get the data from them. For asthma, we'll have it, the last part of the data on the 18th, and they've all agreed to use the same age groups, and then we'll come together so that we're all looking at the same thing, and we should be able to bring that to the group. And those are the 3 MCOs of our area, so I'm thankful for their involvement and their willingness to start looking at this for our area. That's when I will get it, but we'll have to do some data crunching with it's King County that does our data.
Or with the MCOs.
Or with their
depending on what we
MCOs,
get,
how we get it, before we can bring it here. But that is coming, so we can look at it as a region.
So one payer was able to provide some preliminary data. It was a pretty raw data set, not presenting it, without their permission. But there was a map, and it's been blinded, so you don't identify the payer. But I think it's just helpful to get a quick snapshot of looking at right now the hotspots in your region for people with asthma. This is based on their payer population. Now, the payer population can be effect of enrollment and marketing and lots of different things. So you have to be careful not to jump to too many conclusions. But I found it very interesting that, was it Malawa? Malawa down in the bottom seems to have a cluster. And then, Chelan, Moses Lake, and Wenatchee are the others. So you would expect that based on population. But what I found very interesting is the state data showed that a lot of the higher county had a higher incidence rate, and that's per population perhaps, but that is not necessarily showing the raw numbers. But does this raise any questions or insights?
I think it shows some the Mattawa and maybe what's kind of going up above. Freda and maybe that's
They're Freda and Soap Lake.
Soap Lake area a little bit, but really what you're really looking at is population.
It's population.
I know. So
where the people are.
Rick, we can't hear you.
So I'm sorry. I said, the Mattawa is a little interesting because it's got a smaller population compared to some of these other areas. But other than that, this is a population map, and it doesn't really. And I'm not sure. Are they using whoever the data source was? Is this patient's zip code or street, or is this the area of the provider diagnosing asthma? That would be the other thing too.
It is patient zip code.
Okay.
So it looks like in the Chelan area, it's more heavily populated in Manson, if that, I can tell from that map. It's kind of hard to read. Which would have a smaller population, but would have more orchards.
Yeah.
Oh, orchards, chemicals, and fires.
Spray.
You would see that as potentially environmental drivers in those areas.
Well, yeah, there could be some here. That's a lot of. But I think you've got a lot more.
Going on.
It's pretty basic. Is all I guess I would say right now is that it really is showing population centers.
Okay. Other thoughts? Yes.
I guess my question would be, is the numbers that are being reported a ratio of diagnosed cases versus 100 patients? It could be better information than we think it is, depending on how they're crunching the data.
Right.
If it's numbers of patients, it's not going to be accurate at all. If it's number per lives, or like every 1,000 lives or something like that, then that may be a valuable.
Yeah, I think it's, as I understood, I think it's member months. So it's their population of patients with asthma and where they're distributed.
So it'd be just raw counts as opposed to.
Correct.
Which I would like, once we get all 3 MCOs data, to look at rate versus just the raw.
Well, we've kind of hypothesized a couple of contributors, and one was the smoke. To look at that, we'd want to look at exacerbation or a claim for asthma care versus date. Is it more in the summertime versus the winter time? And is smokers, what's the concentration of smokers in these populations as well?
So additional queries might be some time stamping, if you will. of when are the encounters occurring? Is there any variation, or is this spread just normalized? Is it driven by an external environmental factor at certain times of the year? So that's one question. The second is there a comorbidity or co-diagnosis of smoking of the population? Is that something that we can look at to see how many are smokers?
Yeah, it would be interesting to know too. I think in the data is how physicians code is a whole nother issue with asthma, and because people use asthma when they've got a cold with reactive airway disease.
Right.
They truly don't carry a diagnosis of asthma, but yet they're getting that code then. And so can you break this out to true asthma exacerbations that are hitting the ED, and that may actually tell us more. Yeah. So we do get this, and then you get RSV in the middle of the winter months, and, it's kind of acts like asthma. It gets called asthma, or what isn't being called asthma that should be being called asthma. So it's a difficult one. It's both an underdiagnosed and an overdiagnosed disease.
Is there any opportunity in that arena in terms of a collective effort across the environment to improve on the data side of the equation? Any kind of education or programs to help people better code so that you're getting improved data inform over time? Where all the heads go down and go, okay. So.
I think before you take this on, you got to understand if it's a big problem in our area. Are we exceeding a lot of norms of other areas? Do we have a high concentration of asthma? Is this worth our while to really investigate and change and go through coding, talking to docs, doing all this stuff when maybe this is a blip compared to other things that could be being addressed?
Yeah. So, I wonder if we have some kind of higher, just because those docs, those areas code it more frequently, that's going to show up on the claims than it does in other parts of the state. Or
so you may actually have better coding here that could be leading to a higher.
Or better coding. Is that why we're showing a different rates? So are we treating a disease or or data?
And I wonder if it's the overdiagnosing code of it, because when we look at our numbers that Caroline had presented last, it's the medication management. And so if they're overdiagnosing and they don't have the medication, where's that synergy between those? Relative to state, we're the lowest on medication management. So it doesn't have asthma per se, but just the medication management of asthma.
And again, to revisit the breadcrumb trail, the starting point here was to look at the overall aggregate indicators that the state is holding the WPPC accountable. And there were a couple areas there where you were outliers. One was an asthma indicator, but I think that was around the shared care plans, a specific data element. The other was follow-up after discharge with the two other metrics. So we decided, let's look at some data from that perspective. So I'll bring it back to you all. Is this a priority? Is this something you want to continue to do data collection and research? And if not, let's not waste people's energy and let's find another area that's important. But if it is something that you feel is very important and common, then we can continue to drill down. So how would you like to, do you want to commit euthanasia, or is there a lot of energy to move forward? Let's practice what we preach. Thoughts?
Kill it.
David's saying kill it. It's not a high priority.
Wow. Yeah. We don't. I mean, for us as a behavioral health provider, it's not anything. It's not data we collect. It's not a question we ask. It's So it would be for us. It would be a matter of learning from how the data is collected or the process of it. But as a value to our organization, there isn't any.
It's just not high enough on the list for us.
It's important, but just not high enough on the list. It's an important issue, but not high enough on the list compared to other important issues. Other thoughts? And any counter arguments? Anybody feel really strongly that this is a compelling issue?
So,
yes, go ahead.
Go ahead. This is Peter. I think I was conflicting with someone else, so let them go.
No, go for it, Peter.
I think one of the things I'm seeing is that, asthma is an important issue, and our rates may be high, but if you look at the absolute numbers of people that have asthma, it may not rise to the level of really impacting the population as a whole. But Caroline, correct me if I'm wrong, if you look at, all respiratory illnesses, like, COPD, pneumonia, and so forth, which all may have a common etiology, you are starting to get into big numbers. And I think we're not doing well on all those things. So I'm just wondering if asthma is too small. And I realize that that's how things are measured in discrete diagnosis codes, but I'm wondering if we may be missing the forest for the trees.
So one of the things we're going to get from the Healthcare Authority related to the measure that we showed you we were the worst performing ACH on around medication management is we're actually going to get the numerators and denominators so we can get at like how many people are we actually talking about. And also we can do an analysis of if we want to earn revenue on that measure and we need to hit our target as a region, and how many people are we talking about in terms of numbers needed to treat. So we'll have that information, and I think it'll contribute to how much of a priority this is for our region. And then to your point, Peter, about respiratory issues being a high driver for hospitalizations or ED utilization, I think we could potentially get data broken up beyond just asthma and looking at other respiratory issues. But again, we'll have to look at the volume, and then we need to be responsive to whether you think that's a priority. But remains that it's a P for P metric. We will be held accountable to it, and if we don't hit the target, we won't get revenue for that metric. But that's to say that all the decisions as a collaborative should be made because of the metrics. Again, we need to focus on the why and why it matters, and not just do it because it's a project.
So Carol, can you remind me, the data came from medication management?
Correct.
An issue.
Yeah. And the measure is specific to the 75% medication compliance measure.
Right. And so the question is it goes back to coding, and how many people are being given, and what exactly is the measure and the numerator and denominator descriptors, who's included, who isn't. So if someone has a diagnosis because they had a URI and they got a single inhaler given, they didn't have a follow-up inhaler or follow-up PFTs or whatever the measure is because they really didn't have asthma. And are they being included because of how we initially diagnosed and only gave one, so that would be the question I would ask. And we want to address it if it's an issue. I just think we need to dive into the data to understand, is this an issue or are we somehow screwing ourselves by the way we're coding?
Right.
And this is Stephanie Dallin from Moses Lake Community Health, and we took a deep dive into our asthma data, not medication compliance, because that we looked at it from the prescription angle. So, with patients with a diagnosis of asthma, how well were we doing even prescribing the appropriate therapy? And then obviously there's the step further of the patient actually picking it up. But we found that it was very much that a diagnosis and coding issue where patients were just being prescribed, getting a diagnosis of asthma, getting a prescription for an inhaler for an acute issue that wasn't really a true asthma diagnosis.
And I wonder if there's kind of some post-diagnosis putting in order to get that inhaler, that they have to put an asthma code on it, get it covered by the insurance.
Possibly, yeah.
No.
I
have a couple. First thing is that do we have enough information to make a decision on whether we should euthanasia or scrap it at all at this point right now? Second thing is to Gail's point is that we don't collect it. So as behavioral health entities, what is it that we could do? We don't diagnose asthma. We don't code asthma. We don't prescribe for asthma. What is it that we could do to be a player in compliance? In this? Compliance. Okay, that's fine. That's totally fine.
No,
Just want to make sure that's what it is. And again, it comes back to our partnership and how we're working together and pathways and whatever else. But to me, it feels like making a decision on whether we need to euthanasia or not. I don't know where it might be.
So maybe because the data it's not the data we collect. The state's data that they end up saying whether we get pay for performance or not.
Yeah.
So maybe one answer here would be this is just general education, and maybe we need to look at the data. If it's not big enough, doesn't mean we can't all undergo general education about coding, prescriptions, getting people who truly are diagnosed the right things and follow up, and the importance of compliance with medications, and leave it at that instead of a huge project that we're all trying
And
to
the other thing is we've already started down the road with asthma, but might be an opportunity for, this is where we struggle with, these are the gaps we're missing, and taking this piece because we've already started and learning from it as we move down the road with different, medical conditions, whatever else. But
So in hearing,
clearly have pointed out a ton of issues with just the limited data we have here.
so what I'm hearing is continue to reach out to the state, see if we can clarify what the actual numbers are in the aggregate and what the core issues might be.
We will have that by the next meeting, for
Okay.
sure.
So we'll plan on revisiting this at the next meeting. Let me,
Can I just say,
go ahead.
oh, sorry, this is Laurel from Molina. I just wanted to say that, one, I mean, the asthma med management measure is clearly an aligned measure with the MCOs because it is part of our premium withhold measure. So it's definitely something that all MCOs would be focused on. And then also, I think in terms of the data, and just like Wendy's sharing, we've all been in dialogue about trying to provide meaningful data, but it just kind of demonstrates how important it is for all of us up front to have a shared definition of what it is that we're trying to pull so that we're as efficient as possible in terms of generating that data. And I believe we're working on scheduling a meeting to that end, but if there were people from this committee that had strong interest in helping to shape how the data is ultimately pulled, I think it would be great to have them involved.
Anybody interested in that offer? Helping the payers define the data query?
Don't everyone volunteer at once.
For those of you on the phone, we're trying to sort out all the hands that were raised. All right, we'll reach out following the meeting to see if there's any others that might be interested. In the last just couple of minutes to plant the seed, is there any burning platform topic or issue that would lend itself for collaboration across the whole environment? Peter talked about contact centers and access. That was an issue. Anything else is a burning platform?
Screening in a Hispanic population.
Screening in the Hispanic population for?
Breast cancer.
For breast cancer, colorectal. So screening in the Hispanic population for cancers.
Disparity.
It's a huge disparity. It's a lot of social determinant issues. Is that an area that would be of interest to the collective group? Heard some cultural challenges. Is that a potential topic?
Your head, yes or no? Ended up with asthma because no one said really anything, so we ran with it. And then we heard that really wasn't what we wanted, so.
Silence is not consensus.
Silence is not consensus, so yes or no?
So I ask you to think about that in preparation for the next meeting. We'll do some additional data investigation, come back with some information at the next meeting on asthma. And given the information, what might be the portfolio of opportunities for how big a intervention across the collaborative? I was suggesting maybe it's not a large-scale project, maybe it's something that's around coding or education or.
This is a geographic explanation where housing goes, but for the social care, I mean, there are clusters of population. Is it housing? Is it, as you were describing, the molds and the fumes for traffic? And is it because parents can afford to turn their heat up so they do have more mold? What are the
Yeah, if you're going to use a map, you got to get down to like this.
Zip coding.
Not zip code.
Or even.
Right.
Even.
The entire region. So,
yeah.
Yeah, right. Zip code is not going to help.
Not going to do it. Super. Okay, in the back, yes.
Now, I'm pretty sure that on a pretty frequent basis, there are health assessment, needs assessments done. What's the data set? Maybe we shouldn't be off the cuff trying to figure out what we need. I think the work's already been done. I think that resides with the health district.
And us.
Well,
Community.
nobody who knows that data maybe. I think yes.
I'm not sure that
Data that's in the current needs assessment level, and we weren't able to
Yep.
get it.
lower.
Crystal is saying for those on the phone that it's at a county level. The needs assessments are at county level, not regional.
What do they say? What do they say?
So another data point that I think David's suggesting is to go look at some of the needs assessments. That can be both some of the hospital needs assessments that have been done, as well as some of the other county and collaborative assessments. Okay?
All health centers have to do it every 3 years. Health
Yes.
districts.
Yeah.
I don't know the frequency of the hospitals, but I know they have to do it. I'm just thinking, maybe this has already been done. At least point us in a direction.
I don't know. I agree with Crystal. Crystal and I and Stephen worked on the last CHINA in 2016, and I don't think we got that granular, but there is all of the stuff that we looked at is on the doc vault under the CHINA. So, but you've looked at it too, right?
Yeah, I mean, we looked at the health needs assessment and drew a lot from those results when we were doing the project planning and selection process, and it also informed some of the chronic disease conditions that we focused on as a WPCC. So respiratory issues, there's a higher prevalence in our region compared to the rest of the state. Cardiovascular issues, depression. So some of that data was definitely incorporated into the planning, but in terms of getting to this level of hotspotting and then really targeting interventions, those community health needs assessments haven't gotten us there.
And it gets back to that own, I think we have.
Mhm.
Why we can identify it and understand the causing.
Right.
Need to be able to recognize that.
Yeah.
I have kind of a rogue question, I guess. So if we're looking at this truly from our focus of whole person care and the whole deal of behavioral health integration, and that's a primary focus. My understanding that was part of what we were trying to accomplish here was to actually influence some of the measures that may really not reflect true status of our patients. And I know that depression was one of those things where we were, when we're looking at it from a behavioral health integration standpoint, there are better ways to handle depression treatment than only medication, but our depression measures are based on medication. And if we're looking at behavioral health integration and whole person care, better success for our patient may mean that we fail a depression medication measure because that's not what's most effective, or it's more effective in a combination of counseling and medication as opposed to just medication. And it seems to me like if we're going to be coming from a whole person care behavioral health integration standpoint, that would be something where we could be capturing data that not only addresses the P4P requirement, but we could also be capturing some ancillary information as to here's our measures, but the patient population that we did X, Y, and Z that didn't necessarily make us meet our measures actually had better patient outcomes, which is kind of what we're trying to accomplish.
Which piggybacking on that is the
Opioid epidemic, and there's a whole group of folks that go abstinent based rather than going
right
medication assisted treatment. So knowing that those two populations, and so just because they didn't receive something did not mean that they didn't have good outcomes.
Exactly.
Right.
Yeah.
So you're advocating for a potential effort around better management of depression and understanding the data around that, and what are the opportunities to improve and influence those measures over time?
I guess my question is, what's our chances of moving the needle to have our state consider whole person care? Because what I'm seeing, even the P4P measures, is that they're shifting towards pay for performance based on their standards as opposed to truly whole person care. And that's kind of what our role should be, is here to influence change in that way so that that is given as much weight when we're looking at reimbursement based on outcomes, and whether or not a kid decided that they didn't want that medication and so they went to counseling instead. To me, that's better success. So I don't know if we have the ability to move the needle there, or is that just beating our heads against the wall? I don't see any point in beating our heads against the wall if we can't actually cause change to come from that. But it sure would be nice if we could.
So in the light of our time, and I'm just at the edge of the time here, could I suggest we put that on the agenda for the next meeting call, that we discuss that in the context of some of these other proposals and the asthma data? And then that can help inform what are the priorities for next year.
It seems like a more even alignment also for our behavioral health partners. I mean, I do totally get that the behavioral health component of this is going to have an influence with compliance. But I think it's important that we utilize both sides of this with equal weight, I guess, to make sure that everyone is continuing to feel like they have an equal spot at the table.
All right, so to summarize, what we're going to do is for the next call, we will do some additional data analysis working with the payers and the state to bring back some information, do some additional due diligence on the community health needs assessments to see if there's any information available. There have been a couple of proposals, the screening for the Hispanic population for colorectal and breast, depression management are two potential areas. Peter suggested that a broader look at perhaps respiratory disease and its impact as a candidate. So all of those are out there as potentials. I would like to be as data informed as possible, so we're going to try to see what data we can get to help with that. Is that the next step for the next call meeting?
I would just be curious, we took some measures, one, we generate maybe some ideas what we need to do, but then the measures.
Yeah. So if we've not decided what all we're doing, and I'm sorry, I don't make all the whole person care meetings, but maybe we need to make a grid and say, if the state's expecting these performance measures, we've got state data saying as and whatever, we've got our MCO data to say what's their experience been, and then you look at that and choose based on, what's the biggest things, because maybe asthma is huge and we're just downplaying it because, I always don't see that much, but maybe it's a tiny speck. And so, maybe we need to just really look at the data across a couple different things and apply what's most pertinent instead of trying to come off the top of our head to say, this is a problem we face. Because I'm sensing we know we need to do better with asthma, but we don't think it's a huge problem. And there's maybe bigger ideas out there.
We have the second lowest percentage in asthma as an ACH in the state. So,
as a prevalence?
Mm-hmm.
Yeah. I think for family health centers, looking at that asthma was really helpful because it gave us the information that we needed to fix our system within our data collection. It wasn't that we fixed a clinical problem, but we were able to do those drill downs to realize where our system was falling down, whether it was a coding issue or the glitches in the system or whatever. So even though it's not making these big sweeping changes, we probably wouldn't have gotten to some of the changes that we're making systemically for our IT if we hadn't done it, even though it was a handful of patients for us and nothing really changed for our patient population. But by that drill down, it was very helpful for us to fix that measure, and we'll be compliant next time.
So hopefully the payers will help inform too how big an issue this is with the data once that comes together as well.
So Courtney, you shared that asthma we are not at the top of the list for our area. How long will it take for the 3 MCOs who are in this region to give us the data that Dr. Horrigan was asking about? Off the top of your head, do you know that? Or
I will have Molina data by June this week and AmeriGroup just a couple of days later. Yeah, and then Carolina.
All of it, not just asthma.
Oh, asthma is all it, yeah.
I'm talking about
the whole deal.
The whole deal.
Well, we would need to determine what needs to, the process.
Yeah, right.
Each system different way. So we need to agree upon the baseline of what the metrics are for count, and what we are capable of doing across the MCOs. Maybe to be able to do more than America can, et cetera.
So then my question is, prior to the next meeting, could the 3 MCOs get together and discuss that, because you know how you draw down and all that. So when you come back to our meeting in February, we might have a clue. It may not be as exact as Dr. Horrigan was asking for to match it all up, but it might give us a better direction.
Yeah, I think if I could and help Caroline or Wendy help just schedule that.
Andrea from Coordinated Care said that she would be willing to set it up with the 3 MCOs and their IT. So we're just coming back from the holidays, so we should have a meeting to talk about shared definitions, so that when we ask for specific data, that they all pull it in the same way. So that we just have to develop that process for the 3 MCOs. So we are working on that. It just doesn't go as fast as we like it to.
Ways to bring the behavioral health folks into something like asthma.
I think there's always going to be, we're going to have measures that don't apply to the physical health as much, and those that don't apply to the behavioral health